interesting topic. These are my disclosures. This is my agenda. I would try, I'm not sure, but I would try to answer some of these questions during my presentation. But the first one I want to share with you is what's happening in the first-line treatment phase 3 trial in patients with RCC. And if we look at the data about subsequent therapies in the Keynote 4 to 6, Checkmate 9ER, and CLEAR trial, it's well evident that few patients, just 50% of patients receive subsequent therapies, that the majority of these patients receive a tyrosine kinase inhibitor, and that this is very disappointing data. Few patients, about 10% of patients receive another subsequent line after the second one. And then this is very an important message that first line is the main treatment we should offer to our patient. A few patients receive second line. If we look at the guideline, especially we started with the ESMO guideline, they simply recommend to use this another tyrosine kinase inhibitor, the second one in this case, that you have not previously used in the first line. This is very logical, but really unuseful in clinical practice because they don't suggest us what kind of tyrosine kinase inhibitor we have to use. And the similar recommendation have made by NCCN guideline. Here we have a greatest number of options, including belzutifan, including combination of immunotherapy and tyrosine kinase inhibitor, but the main message is always the same. Try to use what you never offer in first line. Then there are a lot of possibilities. We can combine sequencing tyrosine kinase in a different ways. This is theoretically possible. But what are the evidence supporting this possible sequencing in clinical practice? I try to summarize the evidence available for sequencing in these slides. As you can see, there are some of these sequencing that are supported by large randomized trial, some other sequencing that are supported by small phase 2 trial, and some other that are supported by retrospective data, a few cases published in the medical literature. Then what is well evident from this analysis is that cabozantinib is the most used second line. There are 1 phase 2 trial and 2 phase 3 trial that test cabozantinib in second line in patients previously progressed to immunotherapy. What is well evident in all these 3 trials is that the median progression-free survival is about 9-10 months, and the median overall response rate is about 30-40%. This is what we can do with the best we have for second line with cabozantinib. But what is the rationale for sequencing tyrosine kinase inhibitor? One of the possible reasons for this sequencing and the reason why cabozantinib works so well in the second line is that the IC50 for the VEGFR type 2 is the lowest we have. And then if we look at the previous literature, there are some evidence in renal cell carcinoma that support this sequencing based on this rationale. Axitinib works well after sunitinib, cabozantinib works well after sunitinib in the METEOR trial, or it works well compared to sunitinib in the cabozantinib trial. Of course, this is not the main reason, but it could be a biological rationale for a sequencing with a different type of tyrosine kinase inhibitor. There are also different mechanisms of resistance, and this review is very interesting, and they try to analyze the different mechanisms for cabozantinib-based first line and the lenvatinib-based first line. Of course, no one of these mechanisms could be directly used to select subsequent therapy in kidney cancer. This is a clinical case for my practice. This is a 67 years old female, very good clinical condition. EMDC was 1, just because the tumor relapsed within 1 year from the initial diagnosis. And this patient had initial disease with this bone lesion and an adrenal lesion. And for this reason, we try to start the combination of LEMPEM because at the beginning, our idea is to try to decrease the tumor volume and to treat by surgery, by local radiotherapy, the remaining lesion. But after 4 cycles, the patient progressed with appearance of new lesion. And then this was very disappointing because few tumor volume, early progressor. We don't know exactly what would be the best second line for this patient. And of course, looking at our availabilities among different tyrosine kinase inhibitor, we decided to start cabozantinib. And after 1 year, this patient is under control of disease with a complete response on pancreas, partial response on renal gland, and stable disease of on bone lesion. But what is the activity of the cabo after LEMPEM? If we look at the medical literature, pure data of patients treated with a cabo after LEMPEM, their results are quite disappointing. A median progression-free survival of 4 months and a median overall survival of 8 months. And the similar results have been reported for the different combination. When we use cabo in the second line after tyrosine kinase inhibitor, 2.8 months for time to treatment failure and about 8 months for overall survival. Then I think that there is something that may impact the subsequent line, and this is the type of tyrosine kinase inhibitor used in first line. But how to do better? I think we can look at the new tyrosine kinase inhibitor. We can try to increase second line tyrosine kinase inhibitor efficacy by IO continuation. We saw some data presented by Pietro a few slides ago. And another option is to looking at new mechanism of action, such as F2 alpha inhibitors, and zanzalintinib is probably one of the most promising new tyrosine kinase inhibitor. But again, as you can see here, the activity of zanzalintinib depends by the type of tyrosine kinase inhibitor used in first line. And of course, when we use cabozantinib, this activity is strongly reduced compared to other tyrosine kinase inhibitor. And we previously described the possibility to continue immunotherapy by adding a tyrosine kinase inhibitor. And 2 trials tested this strategy, immunotherapy plus TKI compared to TKI alone. And as we said before, no benefit in terms of progression-free survival. We know also no benefit in terms of overall survival and overall response rate with an increase of toxicity for patients receiving the combination. This is probably the end of the possibility to use immunotherapy in metastatic setting. But we can talk about its use in after adjuvant immunotherapy. And another mechanism of action could be the possibility to use F2 alpha inhibitors. LightSpark 005 trial compared belzutifan to everolimus in patients previously treated with a TKI and the immunotherapy. And we know that the results in the overall population were quite disappointing. The median progression-free survival were comparable between belzutifan and everolimus, even if we have an increase in the overall response rate. But if we look at the patients treated in first line with a combination TKI plus immunotherapy, belzutifan was able to reach 9 months of a progression-free survival and an overall response rate that is about 30%. This is quite similar to the result achieved by cabozantinib in other second-line trial. And to be honest, I don't think that belzutifan could be the same or could have the same activity than cabozantinib. Belzutifan could be a good choice for patients progressed after cabo-nivo. What will be very interesting to test if a sequence of LEMPEM followed by cabo could be better or not compared to a sequence of cabo-nivo followed by belzutifan. But we have no data for this comparison up to now. There are other F2 alpha inhibitors, casdatifan. The initial results have been presented this year at ASCO GU meeting by Tony Schreiri. And there are also other molecules under investigation, but these are very preliminary data with the phase one results. Then where we are and when we are going now. You know that we have 2 trials that tested the continuation of immunotherapy plus TKI compared to TKI. Both these trials failed to show a benefit in progression-free survival. LightSpark is positive, but results are not so great, then I can think that there are no way for IO continuation in metastatic patients. Belzutifan has an activity, but to be honest, less than expected. And we are now testing a different strategy. And this is the combination of IF2 alpha inhibitor plus tyrosine kinase inhibitor compared to tyrosine kinase inhibitor alone. There are some limits about the evidence I showed now, until now. Cabozantinib is the most used and recommended second line, but there are no evidence for treatment of patients progressed after cabo-nivo. And this is a problem because cabo-nivo and lenpembra are the two most used combo in the first line. Lenvatinib was included lately in the clinical armamentarium as the same. We have no evidence, not so great evidence for cabo after lempem. LIGHTSPARK-011 is one of the most expected trial in the next months, but this will be completely not useful because patients treated with cabo-nivo lempem should not be enrolled in this trial. PIC1 will probably support the role of cabo, irrespective of the results. And if cabozantinib is highly recommended in second line, there are no algorithms that may predict the possibility to receive a second line. Then we should not avoid to use cabo-nivo in first line, waiting for a possible second line. In conclusion, a new TKI is the most reasonable option for patient progressed after TKI+IO. Cabo has the strongest data. I remember 9 months of progression-free survival, overall response rate 30–40%. Two trials suggest no efficacy for IO continuation, but probably if a patient would interrupt immunotherapy, discontinue immunotherapy due to toxicity, we can reconsider IO rechallenge. New mechanism of action are urgently required, and IF2 alpha inhibitors probably respond to these needs. Ongoing trials are evaluating the efficacy of this combination with IF2 alpha and tyrosine kinase inhibitors compared to TKI alone, and we expect these results. New TKI are really welcome, but please note that the major limit is that cabozantinib and lenvatinib combo works very well in first line, and we don't know exactly what's happening in second line for patients previously treated with one of these two combinations. Finally, I want to thank all the people that work with me in Rome and you for inviting me here. Thank you again.